Yeah.
So thank you everyone for joining us for the second monthly seminar of the Asian Cardio Oncology Society. We have esteemed faculty members with us, and the first session is the basic cardiac evaluation. Our first speaker is Dr. Muthiah Subramanian, cardiologist and electrophysiologist from Hyderabad, and he will talk on basic ECG for oncologists in cardio oncology, what to note at baseline and after different anti-cancer treatments. Over to you, sir.
Hi, thank you so much. I'd like to thank the organizers for the invitation, and I hope I can do good justice to this topic in the little bit of time that we have. I'll just get started. Give me 1 second. So the topic today is the ECG before and after chemotherapy, and I think with the onset of newer drugs being used widely in many hospitals, and we've started to see a large group of patients who have now presented to us with ECG changes before, after, during and after chemotherapy. And basically these ECG changes during chemotherapy, I think we can look at it in two ways. First is a primary cause. It is the drug itself disrupting a specific molecular pathway critical to the development of a specific bradycardia or tachycardia. The second more common one is the effect of the drug on the heart or on the cardiomyocyte, and this leads to damage to either the endocardium or the pericardium, and this causes secondary ECG changes, and this is probably what is more common. And the last two things we need to think about is these patients are often having other drugs and other comorbidities. So the presence of other electrolyte disturbances also have a significant role in these patients' ECGs. And the last one is non-therapeutic factors, such as a previously underlying heart condition or coexisting radiation therapy or adjuvant medication. So these are all, so it's a multiple issues in each patient when they present to us with ECG changes. So I thought the best way to take this talk forward would be just to give 5 case examples that we have encountered in our practice, and maybe a little bit about a discussion about each case as we go through it. So the first case that I'll be showing you is this 58-year-old female, and diabetic hypertensive. Her baseline ECG was totally normal. By normal, I mean baseline PR segment was normal. The QRS was normal. There was no significant alteration at baseline. Her baseline echo was also normal. Her oncology history was she was diagnosed to have a CA breast. She underwent a modified radical mastectomy, and then she was started as adjuvant chemotherapy with doxorubicin. So she did well for the first almost 6 months of her chemotherapy cycle. After 6 months after her chemotherapy, she developed this kind of ECG pattern. And when we see this ECG pattern, there are a few things we need to understand. So first, this patient from a baseline, the ECG that was normal, she has now developed clearly a new conduction disturbance. She remains in sinus rhythm, but now she has developed a complete left bundle branch block. And by left bundle branch block, we can see that the one AVL, we are seeing a peaking in one and AVL and a typical left bundle branch kind of pattern. QRS duration has also become wide. So when we see a patient present to us with this ECG, we are very curious about her symptoms, how they have changed in terms of her breathlessness or new onset angina. And we're also very interested to see her LV function, because this patient had a documented normal LV function before. So if you can see her echo, I'd just like to play it. This is her echo. So this it's not playing for some reason, but the echo showed a global hypokinesia and an EF now of only 30%. So the patient has developed a new left bundle branch block and a new onset LV dysfunction, and as a result of a chemotherapy. So the thing is, we tried medical therapy. She continued to be symptomatic. She also in between had one episode of syncope, and this is something we need to keep in mind when we see patients with new onset conduction disturbances. We need to be aware that a reduced LV function can also lead to arrhythmias on its own. And the problem here we had is she had a right upper limb edema, left subclavian vein was occluded. So we did implant a cardiac resynchronization therapy for her. I'm not going to go into this, but this was the end course of this patient per se. But the main thing I wanted to get to is when you see a patient post-chemotherapy with new onset conduction disturbances, few things need to be evaluated. One is is the patient symptomatic for these new onset conduction disturbances with terms of giddiness, exertional dyspnea, which is very common, and anything like pre-syncope or syncope that this patient had. And few things that I feel are very important is if you see new onset sinus bradycardia in someone who usually had a normal heart rate and their presenting symptom is exertional dyspnea, one thing you need to really consider is something like a sinus node dysfunction. So the next investigation for someone with a sinus bradycardia, if they are not very symptomatic, is a good idea is to do a treadmill testing just to see if really they are having any chronotropic problems. If someone just develops a first degree AV block, sometimes we disregard it, sometimes on the ECG as cursory that the PR is only 220 or 230. But the sign on the resting ECG of a first degree AV block may be the sign of something of a worse conduction disturbance later onwards. So doing something like a Holter monitoring would be advised in these patients. And like the patient I just described, if there is a new onset left bundle branch block, we have to be very careful. Look at the echo, look at the LV function, and also a new onset left bundle branch block can be a sign of ischemia as well. So this is just about conduction disturbances. These are some of the drugs that have been associated with conduction disturbances before. Anthracyclines per se, the only difference between anthracycline-induced LV dysfunction, anthracycline-induced ECG changes is that the ECG changes are completely dose-dependent. While we don't know so much about the LV dysfunction, although enough evidence is to say that that is also dose-dependent as well. These are some of the other drugs, cyclophosphamide, paclitaxel, also have been known to cause complete heart block and left bundle branch block as well. So these are just a few things regarding conduction disturbances. Second patient, 60-year-old female, hypertensive, underwent a hemicolectomy and completed 2 cycles of adjuvant chemotherapy with capecitabine and oxaliplatin. So she presented with vomiting and palpitations, and this was the ECG when we saw her. Few things to note in this ECG is that, so the main striking thing immediately that we see is this is the P wave, this is the QRS, this is the T wave and a long ST segment. So actually this lady's QT interval is now from here to almost the next QRS complex. And a rough marker we keep is that the QT should be less than half of the RR interval. So you can see that her QT interval is now 610 milliseconds. A normal QT interval just for thing is 460 milliseconds in male and 440 milliseconds in female. So this is quite a disturbing finding. So here when we look at it and the obvious, there could be multiple issues. Her vomiting could have led to hypokalemia, hypomagnesemia. This could have prolonged the QT interval. She may have been giving medications for her vomiting, which are to worsen the QT, along with the chemotherapy drug she was already on. So the most important thing when you see a patient with a longer QT or a very long QT like this is first to find her baseline ECG and see how much this QT has prolonged compared to the baseline ECG. Always check the electrolytes because that is often a very easy to miss, but easy to treat cause of a longer QT interval. And oftentimes these patients with chemotherapy are taking other medications as well. Very commonly antiemetics, antibiotics such as quinolones may be there, and this coexistent or the combination of medications may have pushed the QT interval too far. And one of the main things to see is why is it so important? Why does this QT matter so much? Is you need to understand that most oftenly QT prolongation, patient remains asymptomatic. You take out the precipitating factor and the QT usually returns back to normal. But very,
so 2 minutes left, sir.
Yeah, so very rarely what can happen is you can have these kind of very bad arrhythmias where they go into these kind of torsades kind of conditions. So this is also something to keep in mind. So these are some of the drugs that are associated with a prolonged QT interval that we need to keep in mind. Anthracyclines have been known, and we also need to know co-administration of other drugs is also very important. I'd like to just show maybe one, if I have time, one more case. So this is a patient after chemotherapy with 5-fluorouracil developed PVCs on the ECG. Now, when we see PVCs, sometimes it's a little bit altering when we see too many PVCs. So what are some of the red flags for patients with PVCs is a symptom of syncope, a very high PVC burden. If some PVCs are more dangerous than others, and if you see PVCs with more than one morphology, all of these are clues that we need further evaluation of these patients. And main thing to look for when we see a PVC or a VT in a patient with chemotherapy is rule out if there's any underlying LV dysfunction and if there's any acute reversible causes for a PVC, such as dyselectrolemia or fever. And the most common 5-fluorouracil induced ECG change that we often see is patients coming to us with chest pain, which is a very typical vasospasm kind of feature. And here the treatment of choice is nitroglycerin. They usually settle down with nitroglycerin with this kind of coronary vasospasm. In this case, I'll skip. I'll just show you the last case. So the thing that I want to tell you is a 47-year-old male, acute myeloid leukemia, presented the ER with dyspnea, at least 3-4 days after the induction of his chemotherapy. And this was the ECG. This is actually a very, very scary ECG. You don't see a P wave, you see a tall T wave, and you see a large QRS complex. And after seeing the ECG, a history of anuria for 1 day was elicited. And the ABG also showed that the potassium was 8.2. So this is acute hyperkalemia and ECG that was secondary to tumor lysis syndrome. And if we have potassium of 8 with these kind of ECGs, despite our corrective potassium measures, we couldn't bring the ECG back to normal. QRS was widening and potassium was still 7.3. So she required dialysis for this renal failure. Just to keep in mind that hyperkalemia, tumor lysis syndrome, it is life-threatening and you need to rule it out. And ECG is very important in these kind of conditions because most of the time hyperkalemia mortality is because of arrhythmias. So ECG may provide important clues for the presence of chemotherapy-induced cardiotoxicity. The most important thing is careful assessment of the baseline ECG is very important, baseline ECG and echo before we start chemo. And chemotherapy-induced arrhythmias are common, but the majority can be managed with drugs alone. And we should have a low threshold for repeat ECGs after patients with chemotherapies, especially if there is a new onset symptom or a new change in medication per se. So thank you. I'll just stop sharing.
Thank you so much, sir. We'll move on to the second talk. Our next speaker is Dr. Shyam Aggarwal, medical oncologist from New Delhi, and his topic is evaluating cardiac fitness in oncology, when, how, by whom, to whom, cardiology, referral for all, or selected. Over to you, sir.
Vivek, you have my slides now?
Sure, sir. We'll play the slides, sir.
Thank you. So it's a very, very vast topic which has been given to me. So let me see. I'm only going to point out some new things.
Sir, are you able to see the slides on your screen, sir?
I think there's some, I got disconnected. Can you hear me? Yeah.
Yes, okay. Sir, we can hear you, sir.
Okay, I can see the slides. Yes, thank you.
Perfect, sir. Perfect.
So, so this is a very simple list which I thought I'll begin with before I go into the question of who, how, when, which is what Vivek wanted me to share with you. And so, anthracyclines, trastuzumab, VEGF inhibitors, and chest radiation. So these are some of the, things which we understand, most of us, and we are aware of. But let us go to certain new areas which are evolving in a little more detail, which I'll share with you in the next few slides. Next, please. So I think this is an important slide which, indicates that who are at high risk of, developing cardiac dysfunction during anti-cancer treatment, which includes, anthracycline therapy beforehand, elderly patients, radiation, hypertension, smoking, or very young people, patients with LVEF less than 50% or diabetes. So there is a scoring system before you get into chemotherapy. Next, please. So this is a scoring system in which patient-related risk factors such as hypertension, etc., will be there, and then chemotherapy-related risk factors. For example, risk of 4 if somebody is getting anthracycline, trastuzumab. Risk of 2 if somebody is getting drugs like pertuzumab, sorafenib, sunitinib, and so on. So, depending on this calculation, one is supposed to take a call what investigations we should do before we subject a patient to chemotherapy, and especially drugs which have a potential of doing or inducing cardiotoxicity. Next, please. So these are some of the definitions. I'm not going to go into the details of this, which we understand, for example, with trastuzumab or with anthracycline, where there is reduction in the LVEF on follow-up. So these are definitions which are laid down. Next, please. So, okay, now I think some of the drugs, as we understand, HER2 inhibitors, anthracycline, but you see the list of these drugs, TKIs, proteasome inhibitors, platinum, ibrutinib, VEGF drugs, they can cause hypertension, vascular toxicity, such as, 5FU, platinum. So, a lot of drugs are there which have the potential of causing cardiovascular injury. Arrhythmias, I think he just spoke about, including, 5FU, platinum, and ibrutinib, etc. Then myocarditis with TKIs and these immune checkpoint inhibitors, ventricular dysfunctions, as we know. So there is a large number of drugs which I think can be responsible for giving injury to the heart, and therefore you have to be extremely, extremely careful in assessing a patient before these drugs are instituted in patients who are suffering with cancer. Next, please. So now what should we do at baseline? Depending upon, in all cases, we feel the oncologist should certainly do an ECG as a baseline and look at the QTC for all patients who are going to potentially take cardiotoxic treatment. So I think ECG baseline is mandatory. That is one recommendation from my side. Next, please. Again, at baseline in the beginning, patients who have heart failure or left ventricular dysfunction, there we feel the cardio referral should be given and the patient's diastolic and the systolic liver function should be assessed, and that should be done by the cardiology. So if a patient is at high risk for whatever reason, hypertension, diabetes, or heart failure, left ventricular dysfunction, so I think a cardiologist should be involved upfront. Next, please. So again, at baseline in all high-risk cases, one should be doing a cardio referral, and of course, along with the oncologist. Now coming to the role of these biomarkers, like troponins and natriuretic peptides. So the role is not well established, but high-risk patients who are going to undergo drugs like anthracycline. So, there is a school of thought that we should start monitoring their, biomarkers, which are so readily available. So I think, again, with the help of cardiologists, you should look at high-risk patients who are going to get drugs like anthracycline. Next, please. So again, patients who have cardiovascular high-risk features. So again, we should have a cardiology referral, and drugs like, ACE inhibitors or, beta blockers, they should be added upfront before these patients are subjected to known cardiotoxic agents. So I think these things we are not doing at this point in time. There is a need, to my mind, to interact with the cardiologist upfront for patients who have high-risk cardiovascular features. Next, please. So now at baseline for all patients who have hyperlipidemia. So again, the evidence may not be very strong, but I think it is not a bad idea to be in touch with the physician or the cardio surgeon or cardiologist to control the hyperlipidemia, because there is some evidence to suggest that people may develop higher incidence of cardiotoxicity with such chemotherapy drugs like anthracyclines. Next, please. So now all cases at baseline, patients who have liver dysfunction or, patients who are going to go through anthracyclines or through HER2 new therapies or through VEGF inhibitors, I think it is better to have a cardio referral to begin with, as I just said. Next, please. So echocardiogram for patients who are going to undergo therapy with anthracyclines is very, very important, and that is done by the cardiologist. And we need to, take the clearance from the cardiologist for all patients who are undergoing anthracycline therapy and on follow-up. So now another thing which has come up more recently is the global, strain, longitudinal strain, which happens, before the left ventricular dysfunction sets in. So there is some data which is evolving that reduced GLS is predictive of anthracycline-based cardiotoxicity 3 to 6 months in advance. So I think there's an opportunity to initiate cardioprotective therapy before development of reduced LVEF, which occurs in about 7% of the patients. So I think when we are ordering, so it is very simple to calculate the GLS on the part of the cardiologist. So I think somebody who is at a high risk undergoing anthracycline therapy or maybe HER2 new therapy, so we should be asking for GLS. Again, the evidence is building up at this point in time, which is what I learned in my review of literature recently. Next, please. So hypertension is another side effect with the VEGF inhibitors. And as you know, bevacizumab and sorafenib, and even drugs like platinum, taxanes, vincristine, everolimus, carfilzomib, rituximab, which are so routinely used. So I think we need to be careful, and monitoring the blood pressure is important. And if it does go up, then a cardio referral should be taken. Next, please. So follow up. Now, I think the issue is how frequently we should be doing the, cardio monitoring. So important thing is same imaging modality. As we know, we can do MUGA, we can do 2D or 3D echo at the same facility. Ideally should be done. And as I said, GLS imaging is becoming important, should be considered at 3 months interval. Next, please. So again, for follow-up in patients who are at high risk, again, I said the role of these biomarkers like troponin and BNP, etc., is there. And we should do that once we have gone beyond a particular range of doxorubicin, like 250 milligram per meter square. Next. So I think we all are doing the trastuzumab monitoring every 3 months. Next, please. And now there are guidelines. So how to, look at these patients who have ejection fraction, which is say less than 50, but more than 40. So I think if it is more than 40, patient is asymptomatic. People think of adding, you have to involve the cardiologist, and we need to put drugs like ACE inhibitors or beta blockers, etc., and do these markers and see if we can sustain the use of trastuzumab in this situation. Next. Again, anthracycline, we need to add these drugs and involve the cardiologist. So 40 to 50 LVEF is a borderline scenario. Less than 50 and patients becoming symptomatic, we have to stop. Next. So cardiac failure with anthracycline, it is not recommended. I mean, unless it's really emergency or, you have no other drug. And then, of course, you have to think of drugs like, the cardiozaxane. Next, please. Again, with trastuzumab, it should be withheld, and we should do the periodic follow-up at 3 to 6 weeks until there is a recovery of the LVEF. Next. So asymptomatic long-term survivors on anthracycline, we need to do the follow-up LVEF monitoring for long periods of time, every 2 years, after maybe 3 to 4 years. Next, please. So this is another area which we should remember. Patients who get radiation to the mediastinum for the lung cancer or for lymphomas, the coronary artery disease can happen, several years later. And as you can see, even the valvular disease can happen after 22 years. So I think monitoring is required on a long-term basis for patients who are undergoing radiation. Next. And that, of course, is done with the cardio referral. So the other new thing which is now happening is the immune oncology drugs like Pembro, Nivo, etc. And when they become symptomatic, we need to involve the cardiologist because they can have conduction abnormalities, they can have myocarditis, and even, endomyocardial biopsy, etc. And these markers are recommended. So you have to be careful for patients who are undergoing treatment with nivolumab and all these IO drugs like Pembro, etc. So it's an important area because it's emerging now. We need to be aware of this. Next. So I think the list of these drugs are long. I think QT prolongation, you can see arsenic trioxide, dasatinib, lapatinib, which we so frequently use, nilotinib, vandatinib, and vemurafenib, BRAF inhibitor. So the list of these drugs is adding up, and we need to stay updated. Next, please. Thromboembolism I have not touched because I know a lot of drugs which we use like lenalidomide and platinum and thalidomide. We need to be careful, bevacizumab, and there's a long list of drugs which are there with these drugs like warfarin or ecosprin. Next, please. So hypertension we have already covered. There are a lot of drugs like VEGF inhibitors, especially. We need to monitor them very carefully. Next. So in the end, the list shown previously is not complete, and it's regularly, getting updated. For example, osimertinib, I think we all know, can cause, left ventricular reduction in the systolic function, number one. And if you look at the ADURA study, nearly 10% patients had QT prolongation. So, you really need to stay updated with these new drugs and follow up data for some of these, TKIs, etc. Biomarker evaluation should be considered in suitable cases, especially patients who are undergoing anthracycline, etc., who are at high risk depending upon their cardiovascular risk score. GLS, as I said, is a predictor for LV damage and should be incorporated in high risk cases who are undergoing therapy with the cardiotoxic drugs. QTC calculation and arrhythmias are better dealt with by cardiologists, to my mind, whenever you're doing the ECGs. But the threshold, as Dr. I think the previous speaker said, the threshold for doing the ECGs should be lower. So we should be doing more ECGs in such patients. And high-risk cases must involve cardio. Preferably identify 1 or 2 cardiologists in your institution rather than referring them to all of them at some point in time, because I think the concept of cardio oncology should be encouraged in a given institution, so that 1 or 2 doctors whom you can talk to and whom you can collaborate with makes it much more meaningful rather than collaborating with anybody or everybody in the oncology field. So I think I'll close this, and thank you very much for the invite, Vivek. Yeah.
Thank you so much, sir. Now I request our honorary secretary to please moderate the question and answers.
Yeah, thank you, sir. And I really congratulate both the speakers for laying down such simple. I mean, the ECG lecture was really very exciting, and I am looking forward to such kind of ECG series in our Asian Cardio Oncology Society meetings, where we can discuss individual ECGs, because so much we can learn about the ECG changes, and in our day-to-day practice so much is happening on the ECG probably that we are missing. And Dr. Shyam, you really sort of put out guidelines for us as to how, when, and how frequently we should consider cardiology referral in oncology. And I'm really looking up to if we can really form guidelines on this as to what in Asian Cardio Oncology Society we can come to a common consensus. So going ahead with the question, the first one is for our first speaker. So is new LBB more significant than RBB when looking at the cardiotoxicity? Yes.
Hi, thank you. So it's an interesting question. The thing is, any new onset bundle branch block in someone who has previously had a normal ECG is probably significant. How it links to exactly to cardiotoxicity probably depends on that patient in general. But one rule is a new onset, maybe both may be sign of a possible LV dysfunction, but in terms of ischemia, we would take left bundle branch block as probably more significant. And also the heart rate at which it occurs is probably also more important. If it is just at a very fast rate that you're getting these changes and the resting ECG is normal, then we would probably treat it accordingly.
Correct. Coming to the second question, this is also from Dr. Purvish, who asked, how reliable is the QT interval flag, which is highlighted by the digital ECG machines nowadays, what is there reported in the machine? Is it really significant different, as you calculate it manually as what is reported in the machine? And how significant, is the difference? Do you see this in the oncology patients as compared to non-oncology?
So the ECG machine, I would say usually is right. But the problem is sometimes these machines use an automated assessment. And the problem is sometimes if the way they measure it is they measure till the end of the T wave. So if your T wave is too flat, or it's maybe too small, or the QRS is too small, then it's probably not a good idea to go by the measurement. If it is more than 400, then I would start manually measuring the QT to make sure it's normal. And in terms of which patient it matters, it's important to have a previous ECG of the patient when you're looking at the QT, just to make sure there is no abrupt change in the QT.
Yeah. So, the cardiologists are probably more in habit of just by their look, identifying a prolonged QTC. And as you, sort of guided us, what I understand is if if it is more than 400, then we should rather go for manually. And if the QR is short, then we should go for manual. Otherwise, we can rely on the, but probably when you more and more look at the QTC, you start identifying longer QTCs just by the look of it. Yeah. Another question that I had, to ask you that, do you really think, ECG changes can pick up early cardiotoxicity prior to an LVEF decline?
So that's also an interesting question. I mean, the thing is, there are some ECG markers of subclinical LV dysfunction, which I guess is a little bit of the question. And the two things that they find is, one is that If you have your QRS duration increases more than 120 milliseconds, it's a sign of subclinical LV dysfunction that has been correlated to longitudinal strain. The other thing is new onset fragmentation of the QRS, that is increased number of spikes within the QRS, and it starts looking a little different, is also a sign of subclinical LV dysfunction. But in general, some other things to look for are if your voltage in your limb leads has suddenly changed from a normal voltage to suddenly low voltage complexes in that patient, that can also be a sign of LV dysfunction. So QRS widening, fragmentation, and voltage changes in the QRS can be all maybe used as early markers.
Yeah. Thank you, Dr. Muthiah. I mean, really fascinating that if we can really, do certain studies and document these markers being really correlating with, cardiotoxicity, nothing like it, but really good clues to us oncologists as to in ECG also you can look for certain early markers to define, early cardiotoxicity. Another question from Dr. Rajesh Jindal. This is to Dr. Shyam. Sir, how often does a patient need to see a cardiologist when on doxorubicin?
Right. So you see, I mean, if the patient is like a normal risk individual, like a young person who has maybe Hodgkin's or non-Hodgkin's and has no risk factors, such as diabetes, hypertension, or a pre-existing heart problem, etc. So normally, I mean, that my practice is not to refer such patients to the cardiologist, at least in the beginning. So we will like to do a ECG, we like to do a 2D echo, and if everything is normal, so I am actually not inclined to, I mean, my practice is not to send patients for cardiology referral. But then our practice is that patients, for example, who are getting an anthracycline, we even actually just do the echocardiogram after maybe completion of their therapy. So, for HER2 therapy, we are doing it every 3 months. So, I mean, if somebody is high risk, now, for example, I have a patient right now who has a ejection fraction of 50, at the on the baseline. So I am doing his echocardiogram and in consultation with the cardiologist to give him ACE inhibitors, etc., so that his ejection fraction doesn't decline. And I'm doing the echo and I'm in consultation with the cardiologist every 2 cycles or every month. So, it depends on what the baseline, the risk score is of a given patient who is undergoing anthracycline therapy.
Correct. Okay. Thank you, sir, for the brilliant insights, and thank you, Dr. Muthiah, for your brilliant talk and insights. Let us proceed with the next session. Kashish.
Thank you so much, sir. We'll now move on to our debate. The premise of the debate is a 60-year-old female with borderline cardiac fitness requiring curative treatment for DLBCL. We'll go with the first is the oncology debate. Anthracycline-based chemotherapy is essential for achieving best outcomes, and it's worth taking the risk. Speaking for the motion is Dr. Vishwanath S, medical oncologist from Bangalore. Speaking against the motion is Dr. Venkatesh Ekbote, hematologist from Aurangabad. And our chairperson for the session is Dr. Menon, hemato-oncologist from Bangalore. So I request Dr. Vishwanath S, who will be speaking for the motion, to start. Over to you, sir. So you'll have to unmute your mic.
Yes. Are my slides visible?
Yes, sir, your slides are visible, sir.
Okay. Thank you. Thank you so much. At the outset, I would like to thank Purvish Parekh sir and Dr. Vivek Aggarwal for this wonderful opportunity. So the topic for today is it's a debate basically in anthracycline-based chemotherapy is essential for achieving best outcomes, and it's worth taking the risk. And I will be speaking for the for the motion, and the premise, the case is actually given to me is a 60-year-old female with borderline cardiac fitness. So known case of diabetes, hypertension, and ischemic heart disease with an acute coronary syndrome 2 years ago, with preserved LV ejection fraction requiring curative treatment for diffuse large B-cell lymphoma. So with standard R-CHOP and the dose-adjusted EPOCH-R, we know that both of these regimens incorporate anthracyclines. There is a 30 to 40% of patients with high-risk DLBCL which will relapse. And 40% of patients with DLBCL are actually elderly, over the age of 60 years. Frailty and comorbidities may make treatment decision quite complex. And guidelines for unfit patients mainly rely on only phase 2 studies, as well as retrospective and population-based data. So there is paucity of randomized controlled trials. And decision regarding anthracycline versus non-anthracycline based regimens and when to dose reduce, when to omit anthracyclines is very complex and is very subjective. So we do know that there are a lot. DLBCL is a spectrum. We have patients with double expressive lymphomas. We have double hit lymphomas, and we have the conventional GCBs with very limited stage disease who do wonderfully well. So it's a spectrum. So we do know that these high risk patients, as well as certain other cases, they do very badly even with R-CHOP and dose adjusted EPOCH and including some high intensity regimens. These are all to show that, all of these have incorporated anthracyclines, and the patients still have, there are a lot of patients who do relapse and do not have a great outcome. So one of the most important factors in this is to assess the patient's fitness. Often subjective with no consensus on which tool to adopt, how to integrate the tools into decision making and impact on patient outcomes. And most important, these assessment tools also have got limitations, as we as oncologists have very limited knowledge of these tools, how to apply these, and it's often time consuming. And most importantly, we may require a geriatrician, which is not always available. And there are a lot of tools like comprehensive geriatric assessment and the Charlson comorbidity index, etc., which tool to adopt, and maybe unrealistic in patients like lymphoma, where we want to start treatment ASAP or as soon as possible. So the goal is to objectively categorize patients into fit, unfit, and frail. So of course, there are tools, the G8 tool, the Charlson comorbidity index, the comprehensive geriatric assessment score. So all these are there, but which one to adopt is always a consensus issue. So anthracycline-based chemotherapies as of today remains a standard of care in most patients without cardiac complications or contraindications. And in patients who are less than 80 years of age group, including the unfit, please mind that statement, and fit patients 80 to 84 years of age group. A literature review of close to 11,000 patients over the age of 60 years with diffuse large B-cell lymphoma, which included 9 retrospective cohort studies and 2 large SEER Medicare database analysis, revealed that the 3-year OS where anthracycline was used was 63%, and where anthracycline was not used was 44%. You can see the great difference. And can we improve the tolerance of anthracycline patient regimens even in those unfit patients? That is the question, not omitting it. So we have this R-mini-CHOP and the ofatumumab mini-CHOP, which came up in 2011. The same author, Perret et al., published in Lancet Oncology, one in 2011 and one in 2017. Both were phase 2 studies, I do agree, but newly diagnosed diffuse large B-cell lymphoma, very elderly patients, more than 80 years of age group, decent number, 149 patients. And we do know that the mini R-CHOP dose of 25 milligram per meter square of the doxorubicin, and we do know the other doses. And the 2-year OS was 59% and the 2-year PFS was 47%. Similar results were also published by the same author. Instead of rituximab, he used ofatumumab and the similar doses of mini-CHOP. So in our mini-CHOP, when I looked at the review of literature, and you can see here that patients who had cardiac arrhythmia or cardiac cause, grade 1, grade 2, grade 3, grade 4 toxicities are very few. This is something which we have to remember. So this is again to talk about the SEER database. I did speak about this. You can see that patients, such a large number of patients, 8,262 patients, you can see that those who did not receive anthracyclines, you can see that the outcome is much inferior as compared to patients where anthracycline and rituximab was used. This again to talk about the Asian population, a large number, 4,445 patients over 60 years of age group. And you can see here, R-CHOP did the best. And you can see that the ones without the anthracycline, you can see that the outcome was not very good. This goes to say that anthracycline is very important. So there has also been a study, a retrospective study from 8 UK centers of 690 patients over the age of 70 years. They looked at 70 to 79 year age group and more than 80 year age group. You can see that the dose intensity, when it was reduced to less than 80%, in the 70 to 79 year age group, there was a difference in the outcome, but not in patients who were over the 80 years of age group, where the intended dose of less than 80% and more than 80% did not alter the outcome. So again, the CalGB 50303, though it was a negative trial which looked at R-CHOP versus dose-adjusted EPOCH, we do know that Around 43% of the patients were over the age of 60 years. And how many patients with cardiac events? Very few patients in the R-CHOP arm as well as the dose-adjusted epoch arm. This goes to say that such a large number of patient cohort still tolerated the R-CHOP as well as the dose-adjusted epoch arm, even elderly patients. So the MD Anderson retrospective data, again, a very decent number, 207 patients 80 years of age or older between 2002 to 2014. And you can see that 70% received R-CHOP, 6% epoch arm, and of course, few number of patients who received the non-anthracycline based regimens. Goes to say that R-CHOP and dose-adjusted epoch arm patients did much better compared to non-anthracycline based regimens. So can we use anthracycline-free regimens? That is the question here. You can see here various regimens. You can see that the largest number of patients was only R-mini-CHOP and the ofatumumab mini-CHOP. And you can see here the outcomes at 2 years. It is very difficult to comment on anthracycline-free regimens where gemcitabine was replaced instead of doxorubicin. Very few numbers, 61 patients. It's impossible to talk about this outcome here. And RCEOP where etoposide was used instead of doxorubicin. Again, we cannot talk about this outcome, very few numbers. So most importantly, I wanted to also comment here that when you use etoposide instead of doxorubicin, look at the non-GCB. We do know that with R-CHOP, patients do well. Irrespective of GCP, non-GCP, I do know that we do know about the R-square CHOP, but you can see it's not as inferior as this. So using etoposide instead of doxorubicin is not at all the answer here. We also have some cardioprotective strategies. Dr. Shyam Aggarwal sir pointed out very clearly that this here, if you see this overcome trial, largest randomized control trial where AC inhibitors and carvedilol has been used, and patients with non-Hodgkin lymphoma were also involved in the study, included in the study, and you can see that the LV ejection fraction decline at 6 months in the control group versus the intervention group. The intervention group, there was preservation of the LV ejection fraction. This goes to say that using these drugs, optimizing the cardiac function in borderline patients can go a long way in using anthracyclines in these borderline fitness patients. To conclude, evidence-based guidelines for treating less fit patients is limited, and unless we have large randomized control trials between anthra versus non-anthra based regimens, it's impossible to omit anthracyclines. Maybe dose reduction may be an answer. Anthracycline based regimens are currently the standard of care. Patients aged 70 to 80 years of age group, attenuated R-CHOP or dose reduced R-CHOP, mini-CHOP can be considered. More than 80 years of age group, no benefit from full dose R-CHOP, yes, R-mini-CHOP may be considered. And cardioprotective strategies like using AC inhibitors and beta blockers can go a long way in delivering anthracyclines in these borderline cardiac status patients. Thank you so much for a patient hearing.
Thank you so much, sir. Now I request Dr. Venkatesh Ekbote to speak against the motion. Over to you, sir.
Hello, everyone. Am I audible?
Yes, sir, you're audible, sir.
Right.
So would you like to share your slides, sir?
Okay.
Yeah.
I'll do one thing. I'll share my screen.
Yeah, sure, sir. Please go ahead.
Yes, yes. I'll share my screen instead of one moment. So, I'm not sure what is happening over here. Okay, just 1 minute. So, not sure why the screen is not sharing. Has someone? Yeah.
Sir, I've shared this slide, sir. So due to want of time, sir, can I share the screen, sir?
If you 1 minute, I'll just
yeah, sure, sir. You can just try again, sir.
Yeah.
Yeah, there you go.
Yeah, here you go. All right. So are we? Vivek Aggarwal and Dr. Purvish Parikh sir, Dr. Hari Menon sir, all stalwarts. Thank you for inviting me and asking me to speak about in this particular debate. So for all us hematologists and oncologists, usually the cardio oncology starts and ends at anthracycline and cardiac trouble, which is caused by anthracycline. So I think this is a very relevant sort of a debate in that circumstance. I hope I'm audible, right?
Sir, you're audible. Sir, you're audible, but sir, your network is low.
Okay.
Sir, can I stop your video if that's okay,
Hello.
sir? So your network bandwidth is low. Can I stop your video?
Stop. Please stop his video so that we can hear him better.
Yes, sir. Please go ahead, sir.
Right. So I'm speaking against the motion of Dr. Vishwanath, who has tried to convince you that this is the treatment of choice for our particular patient. So he has made very crisp and very good points, and I would like to rebut them. So to start with, since we have a point of reference and the patient is in our clinic, let's go ahead with what we usually consider as a thought experiment when we decide which treatment should be offered and how. So here we have a balancing act we have to do in decreasing the disease related mortality without increasing the treatment related mortality. And the question that we are trying to answer is whether anthracyclines will make a difference or not, and whether it is justifiable. So if you look at this pyramid, the base of the pyramid actually is about patient assessment and performance status and organ status assessment. Then the big chunk comes as disease assessment. Then comes whether there are monoclonal antibodies which we can use in this circumstance. And then comes the anthracycline. So frankly speaking, to me, when it comes to anthracyclines, it is more to do with the toxicity than efficacy in this circumstance. Now, if we look at the case more carefully, my friend Dr. Vishwanath, but the whole premise of his basis was based on population-based data, which is retrospective. Again, it has its own biases. It is also population-based, so I don't think we can apply it to an individual. Second thing is, he also quoted a good amount of trial data. Again, most trials have excluded patients who we are referring to right now. In this particular case, a patient who has multiple comorbidities and an underlying coronary artery disease. Most trials will, in fact, all of them will exclude this in their assessment. The third thing is, in this particular case, there is no performance status which is mentioned. So again, that is another questionable problem. So what do we know about the disease? Here we only know that this patient has diffuse large B-cell lymphoma. We are not aware of the stage, self-origin, and double hit or not, and the IPI of this lady. So I would like to briefly recount as to what we are trying to achieve by looking at all these parameters. So what will help us in deciding? So we already know this pioneering trial. It established RCHOP as the standard of care, but at what cost? If you look at the table on the right side, you will see that it is basically 50% of patients developed cardio and lung toxicity of some form, and almost 10% of them were grade 3 and grade 4. And ever since that trial has come, if we look at data about RCHOP and heart disease in DLBCL, we'll be looking at sort of a needle in a haystack. That's because trials exclude, subsequent trials have excluded patients with cardiac disease. So it's non-informative in this regard. Subsequent trials do not report cardiac outcomes or associated cardiac risk factors which led to these outcomes. Those who report these outcomes are very sketchy and non-specific about it. They are just clubbed, everything is clubbed under cardiac adverse events. They are not specified cardiac endpoints. And subsequently, no post-treatment monitoring screening of asymptomatic patients has taken place. If you are, as a Cardio Oncology forum, one must be aware that regular screening of asymptomatic patients can actually improve the tolerability of patients, and you can pick up heart failure which is asymptomatic and intervene early. We'll come to that later. The rest of the trials you have seen so far are totally single center, more single center than multi-center, and wherever there is multi-center, it's basically population based, which does not apply to this particular patient. And of course, there are no randomized trials to answer this question because of all of the above reasons. So what is the new what is new on this account? And this is cardiovascular adverse events chronicled as literature based data. Again, it has its own drawbacks, I agree, but it has also uncovered a lot of problems in reporting adverse events when it comes to trials and even publications. We are looking at almost 40% of these 137 studies, which showed high risk of bias for incomplete outcome. And in addition, there was selective reporting in another 39% of these studies. Only 28. Hello, can you hear me?
Yes, sir. Please go ahead.
Yes. So only 28% of studies reported an incidence of heart failure, and even a smaller number was actually performing active cardiac screening in these studies. So what does this study particularly show? So there is a heart failure pooled proportion of almost 4.62, that is almost 2 to 3 times the normal population patients develop heart failure. If you screen these patients post chemotherapy, this proportion goes up to 11%, almost 12%. Again, in this patient, we have in this case, we have a female patient. That is an additional risk factor which has been identified for severe cardiovascular events. And old age, of course, 65. She's 60. So that goes in favor of her. Again, in other studies, in patients who are off anthracyclines, the risk of heart failure is only 0.8%. Whereas it is up to 8% in patients who undergo anthracycline therapy. And this risk actually increases cumulatively over a period of time. Nobody has actually looked at it. That is because we are totally obsessed with our EFS and OS endpoints, whereas the uncharacterized and unreported morbidity has been totally overlooked in the race for a better overall survival and event-free survival, which we usually report for first 1 or 2 years at the most. My friend himself, opined and agreed that many of them still relapse even in this circumstance. So we must look for alternatives, and we already know this slide. There are multiple alternatives replacing gemcitabine, etoposide, bendamustine, and oxaliplatin and gemcitabine at the level of CR and overall survival in this circumstance a bit off when it comes to PFS. So why is it important to look at this data? Because there is a selective advantage in certain populations. If you look at the R-GEMOX protocol, it has no anthracycline, and it is tested safely in patients 70 years or older. 3-year PFS is comparable to the standard R-CHOP, and in fact, in patients who have low IPI, 85% of them have 85% progression-free survival, overall survival, as compared to people who have more IPI. So this is an important landmark, and that's why a China study, which will come up subsequently, should be of interest to most people. Again, in this R-Benda, the same thing. There is a trend towards better survival in lower IPI category risk. This particular trial also looked at the actual comorbidity, not just the comorbidities, but actual functional status of the patient, and age was just a number. So that is also an important thing that we must incorporate in this circumstance. Again, the cardiac.
So sorry to interrupt you, sir. Can I request you to conclude? We're running out of time.
Yes, these are the last couple of slides. So only 4.4 or only 9% patients developed toxicity, cardiac toxicity. Again, he has already showed us that if we replace etoposide, the GCB variant can actually give us above 80%. So this is my last slide. To conclude, I would still look at replacing R-CHOP with probably an R-gemcitabine or an R-etoposide based regimen in this circumstance, and try to decrease her overall increase her overall quality of life and decrease the heart failure risk in this circumstance. But even if So this is the final slide that I would like to conclude with. Thank you for your attention.
Thank you so much, sir. We'll now move on to the expert comments. I now request our expert, Dr. Hari Menon, to please give his comments. Over to you.
Yeah, can I? Thank you. Thank you, Vivek, and thank you, sir. Thank you, Purvish, sir, for this opportunity. There are pros and cons about, as would be true for any debate. And over here, we are talking about anthracyclines, whether it should be used. And in this particular patient who is given as an example where we should use it. Now, there is no questioning the utility of anthracyclines in terms of inducing good responses and better responses, and probably which translates into better relapse-free survival and also overall survival. But can we use it in all patients is the question. And we have to be really judicious when we try to use it, because we are talking about a cancer that is going to have long-term survival. And we are talking about a problem that is induced by our therapy, which can actually make the patient a cardiac cripple. So the key to the whole situation is to choose your patients right and not look at those parameters, which such as relapse-free survival and overall survival as the only criteria for choosing a treatment. As has been alluded by Dr. Ekbote also, that one of the meta-analysis, the largest meta-analysis did mention that we are underreporting the cardiac events that are happening, which has gone up from almost 1.64% to almost 11%. But having said that, it has got its limitations, because the cardiac events were very generalized. It was not just about a low ejection fraction or a decreased myocardial function. They included things like hypertension, cardiac arrhythmias, and so many things. So one has to look at in a balanced way as to what we can use, where we can use anthracyclines. I would certainly agree that in this particular lady who's 60 years old, has ischemic heart, has history of a coronary event, also has a history of diabetes and hypertension, would make us a little wary about using anthracyclines over here. Another important thing is about the monitoring of such patients on the long run. More than 98% of the cardiac events, cardiac toxicity, seems to develop within the first year of completion of the therapy. So there has to be a close monitoring. Because why do we say this? Is because even if we were to use anthracyclines in these patients, and we were to encounter early events of cardiotoxicity, we probably can go ahead and use suitable measures and probably revive the myocardium to a certain extent, so that they can the cardiac functions can improve. And so there is a great role for monitoring such patients longer period, which is not being done. And even if you look at that meta-analysis, less than 10% of the studies actually had a monitoring which was as per the guidelines laid down by ASCO and ESMO. So these are some things that have been. It is not like about treating everybody with anthracyclines. It is about a judicious use of anthracyclines. We have to use, there's no questioning about the utility of anthracyclines, but use it judiciously, and as is the principle in medicine, first do no harm. And that is what has to be kept in mind.
Thank you so much, sir. We'll now move on to the next debate. This is the cardiology debate, and the topic is biomarker monitoring is mandatory for monitoring treatment of this patient. For the motion, we have Dr. Hisham Ahmed, cardiologist from Kochi. Against the motion, Dr. Anuprita Daddi, internal medicine specialist from Mumbai, will be talking against the motion. And our expert is Dr. Hemant Madan, who will be giving the expert comments. So now I'd like to request Dr. Hisham Ahmed talk for the motion. Over to you, sir.
Yeah, thank you for the invitation. Thank you, Purvi sir, and thank you, Vivek. It's a pleasure to be here as always. So I think switching gears from the previous debate, where we had the debate regarding the choice of the agent, we'll skip forward. Yeah, so we'll skip forward to the second debate, which is based on the clinical premise of a 60-year-old lady who's a diabetic and hypertensive and who has documented coronary artery disease, acute coronary syndrome previously, and a preserved LV ejection fraction. We don't have details as to what the ejection fraction was, but we have information that it is preserved. And the management plan is curative therapy for diffuse large B-cell lymphoma. So the motion for which I'm seconding today is the biomarker monitoring is mandatory for the treatment of this patient. So I think we're very fortunate in the sense the application of cardiac biomarkers in cardio oncology has received quite an evolution over the last 5 to 6 years. And in fact, we were we had a position paper which came out late in 2020 by in the European Journal of Heart Failure regarding the appropriate use of serum biomarkers in cancer patients who are receiving potentially cardiotoxic cancer therapy. And this is a positions paper which I would definitely recommend everyone to go through because it has very interesting perspectives, and some of the perspectives are at the foundation of today's debate. So what does a biomarker in cardio oncology really aim to achieve? So basically, we're trying to achieve baseline risk stratification. We're trying to detect early cardiovascular disease during therapy and following therapy. And we're also trying to select certain patients for potential cardioprotective therapy if they do have clinically significant fluctuations in biomarkers. And of course, identify patients who have completed their oncological therapy who may require long-term cardiovascular disease follow-up. So this is the scope of a biomarker in cardio oncology as of today. So essentially, baseline, we always start at baseline cardiovascular risk stratification. So this is one of the baseline cardiovascular risk stratification for anthracycline chemotherapy is what we're discussing today. And therefore, this is one of the performers in the position paper. And as you can see a significant list of risk factors on your left-hand side of the panel, and which has an individual score ranging from medium, high, and very high. And of course, you can see the level of evidence. And of course, you can see the paper references to the right side of the panel. So in our patient, we have myocardial infarction, acute coronary syndrome, we have hypertension, and we have diabetes. And if you follow each of these parameters to the right side, you can see that the score is high, and it's medium and medium. So it's a combination of this. We would have to consider this patient as a potentially high risk patient who might develop potential cardiotoxic therapy during the course of anthracycline therapy or after that. And as you can see, in addition to these factors, you have a whole range of additional risk factors which one can use clinically and sort of clinically estimate the risk, the patient's individual risk of having potential cardiotoxic therapy. And of course, I'm not going to dwell regarding the mechanisms of anthracycline cardiotoxicity, which we're all very familiar with. And we know broadly that it can present in an acute early onset or a chronic form, acute being the most uncommon of them, the most common of them being the early onset, approximately 20 to 30%. And it's interesting to note that even if it's 20 to 30%, it's 1.6 to 2% of heart failure events, which are ultimately drawn from that 20 to 30% pool of patients who might develop early onset cardiotoxicity. And of course, we're very familiar with the chronic cardiotoxicity of anthracycline toxicity. So which biomarker can we use in the context of anthracycline chemotherapy? So we can use cardiac troponin, which is an indicator of myocardial injury, and of course, natriuretic peptides, BNP or NT-proBNP, which can reflect increased intracardiac increase in pressure, essentially heart failure. So do we have data that these two biomarker evaluations are of cardiovascular consequence? And of course we do. So these are some of the landmark papers. I'm just remarking on the landmark paper. So this was a seminal paper by Daniela Cardinal, who's considered to be one of the early pioneers in cardio oncology, which clearly demonstrated that for those patients who had a cardiac troponin positivity, there was a steady decrease in LV ejection fraction as time goes by. And this is one of the earliest papers which actually drew attention to the concept of biomarker application in cardio oncology. Moving forward, this is a paper from the same group in which they looked at high-dose chemotherapy regimens in high-risk breast cancer patients. And they also found that the LV ejection fraction clearly and steadily declined in those patients who had troponin positivity. And this was a follow-up study over 12 months. Again, this is another seminal paper which demonstrated the concept of biomarker monitoring and its correlation with potential LV ejection fraction decline. This was another landmark paper by Crosby et al. So they assessed echocardiographic parameters and biomarkers for the extended prediction of cardiotoxicity in patients treated with anthracyclines, taxanes, and trastuzumab. And as you can see on this on the bottom of this panel, you can see that a combination of an elevation of the troponin I of more than 30 picograms per ml and a global longitudinal strain, when you combine with imaging, offered the best sensitivity and specificity of around 53%, sensitivity of 87%. And what's very impressive here is the negative predictive value of close to 91%. It can also potentially identify at-risk patients who may benefit from cardioprotective therapies, the monitoring of biomarkers. So we are all familiar with the trial called SECHI trial, which essentially demonstrated that carvedilol can potentially result in a significant reduction in troponin levels. And this is in a population of breast cancer patients who received anthracycline-based chemotherapy. We're also very familiar with the PRADA trial, which also demonstrated that metoprolol can potentially attenuate the troponin response. So biomarkers can be modulated by potential cardioprotective therapy. And the implications of such modulations may be evident in much more larger, well-designed trials as time goes by. What about natriuretic peptides? It can detect LV dysfunction earlier and identify cardiotoxicity earlier, and it can also identify at-risk individuals. Some of the landmark data is from the Scovard et al. Group, which clearly concluded that the BNP can accurately predict chemotherapy-related cardiotoxicity and the potential risk for overall death. We have another landmark paper by Susanna Scarpa et al. They looked at serum biomarkers and their evaluation to predict chemotherapy-induced cardiotoxicity in breast cancer patients. And in this paper, they showed a significant elevation in NT-proBNP and its association with 1-year mortality, again, implying that the BNP is a very important marker. This is another landmark paper in which they looked at cardiovascular biomarkers in total in patients with cancer and their association with all-cause mortality. As you can see, with NT-proBNP in a group of close to 550 patients, there was an interquartile hazard ratio association of 1.54. And for troponin, you can see there's an interquartile hazard ratio of 1.21 as independent predictors of all-cause mortality. What about predicting late onset anthracycline cardiotoxicity? And that data is much more robust from the pediatric subset. And essentially, this trial looked at changes in cardiac biomarkers during doxorubicin treatment of pediatric patients with high-risk acute lymphoblastic leukemia and its association with long-term echocardiographic outcomes. And clearly, it stated that troponin T and NT-proBNP may hold promise as biomarkers of cardiotoxicity in children with high-risk ALL. And of course, definitive studies are needed to further illustrate this concept. So in summary, the most recent evidence, we saw the landmark papers, the most recent evidence has been, this is a tremendous read in terms of a meta-analysis, and this is a meta-analysis of troponins and BNPs for the prediction of cardiotoxicity in cancer patients. This was published in the European Journal of Heart Failure in 2020. And as you can see over here, troponin had a negative predictive value of 93% in terms of predicting potential cardiotoxicity. And when the troponin levels were elevated, you can see that it was associated with an odds ratio of 11.9 in terms of prediction for potential cardiotoxicity. And if you look at the mean BNP and the NT-proBNP, you could see that the available evidence also clearly seemed to indicate that it had a significant role to play in identifying patients who may go on to develop potential cardiotoxic therapy. So assessment of troponin levels may qualify as a screening test, and troponins performed much better than BNP in this regard. So this is one of my last slides. So the position paper, which I showed in the very first stage of my presentation, essentially outlined a timetable for biomarker surveillance during and after anthracycline therapy. And as you can see, it is essentially determined by the baseline risk of a patient. And depending on the baseline risk, one can pursue different time intervals during chemotherapy and following chemotherapy for the monitoring of BNP or NT-proBNP or cardiac troponin. So in summary, the current recommendations for biomarker use in predicting potential cardiotoxicity are based on expert consensus opinion. We all know cardio oncology is a nascent field. More data is being generated in this field as days go by. We do not have hard guidelines, but we do have expert consensus opinion. The evidence is definitely gathering for biomarker use in cardio oncology. Although the timing for cardiac biomarker measurement is a topic of debate, probably it can be a point of debate at another meeting of ours. And as we saw in the previous slides, what a biomarker achieves is baseline risk assessment, diagnosis of cardiovascular disease during therapy, of cardiovascular disease following therapy as well, and identification of patients who may benefit from cardioprotective therapies. But if there is one point, standout point, which comes from the analysis of all these landmark trials and the recent meta-analysis, it is this: increased cardiac biomarker concentration during evidence-based cancer therapy should be interpreted in the appropriate clinical context and should not, and I emphasize, should not automatically lead to cessation of cancer therapy. Thank you for your patient listening.
Thank you so much, sir. Now I request Dr. Anuprita Daddi to please talk against the motion. Over to you, ma'am.
Can you see my screen?
Not yet, ma'am.
Now?
Still not yet, ma'am.
Okay, wait. Now?
Yes, ma'am. Now I can see it.
Okay. Okay, good evening, everybody. Is biomarker monitoring mandatory? My colleague has just said he believes. Slow down here, the evidence isn't complete. Various risk factors associated with chemotherapy-induced cardiotoxicity, you're all aware, it's not only the drug class or mode of administration of cumulative dose, but it also more other risk factors. Now, this is pathophysiology of anthracycline-induced cardiotoxicity, which is not only limited to ROS, but is a huge cascade of reaction leading to mitochondrial dysfunction and DNA strand break. Question for audience: do you routinely use cardiobiomarkers in the care of your oncology patient? Let's see what guidelines say. Various guidelines published on time-to-time basis have acknowledged the need of biomarker for early detection of cardiotoxicity. However, the recommendation of their use in daily clinical practice is limited due to lack of adequate evidence, and it is not recommended, and even in it's not recommended in surveillance of cancer survivor. Coming to existing cardiovascular biomarkers, CPK-MB, owing to short time of serum elevation, imperfect cardiac specificity not studied, mostly studied biomarker are troponin and BNP. Now, this is the landmark paper which already my colleague has discussed, which was published by Daniela Cardinale in 2000. She studied 204 patients and concluded that elevation of troponin I predicts the development of future LVEF depression. But my dear friend, the duration was followed was only 9 months. Patient with history of ischemic, valvular, hypertensive heart disease, uncontrolled hypertension, left ventricular ejection fraction, acute or coronal insufficiency were excluded from the study. Previous treatment with anthracycline and radiotherapy was present. And we all know that cumulative dose of anthracycline is itself a high risk for cardiotoxicity. Troponin I, creatine kinase, were measured before, immediately after 12, 24, 36, 72 hours, and after each cycle of high-dose chemotherapy. This shows that multiple samples are needed. 3 patients developed symptoms of heart failure during this course, requiring cardiovascular treatment and intervention. Those 3 patients had both troponin I and CK-MB positive, and this shows that role of multiple biomarkers are needed. The time course of this cardiac damage is unclear. Further studies are needed to clarify whether patient with acute minor myocardial injury showed increased troponin I increment and prolonged LV ejection fraction reduction will develop an irreversible dilated cardiomyopathy. This is another study published by same author Daniela Cardinale in year 2004, studying prognostic value of troponin I in cardiac risk stratification in 703 patients. Limitation where troponin I peak value was observed at different intervals. Hence, several samples for each patient were needed. Furthermore, the best time point beyond which a negative value can assure that no further troponin release will occur was not identified. And again, these are various systemic review of literature, recommendation for use of biomarkers for prediction of chemotherapy-induced cardiotoxicity, right from the year 2000 to 2015, 17, 18. And various observations from this studies, a sampling protocol is not homogeneous, timing of samples cannot be specified, there is necessity to collect several blood samples to demonstrate the positive increase of marker. The mechanism responsible for troponin release after chemotherapy is still not defined. The persistence of troponin elevation observed in some studies after 1 month, more from the finish of chemotherapy, suggests that occurrence of release pattern is different from ischemic injury. The low incidence of coronary risk factor, absence of history of coronary artery disease, and lack of any symptoms associated with typical ECG changes in patients studied support the non-ischemic etiology of serum troponin increase after chemotherapy. In acute coronary syndrome, indeed, troponin typically returns to baseline within 10 days and is associated with and not followed by ventricular dysfunction. Increased troponin I could also be elucidated by acute anemia and sepsis. So conclusion are no single measurement is perfect. Discordant data surrounding the utility of biomarker. Biggest limitation is timing of sample cannot be specified. Multiple samples are needed. Time pointage with negative value reach 100% of specificity for no further troponin release cannot be defined. There is a need of new biomarker that can detect myocardial injury even earlier than troponin. Feasibility of repeated blood sampling, an issue of cost effectiveness, is unsuitable in some ways for outpatient because they would need daily monitoring. So in summary, a well-designed prospective trial with good statistical power, long-term follow-up are imperative to address this outstanding issue. And hopefully they will provide physician with the answers needed to manage this group of challenging patients. And what about late cardiotoxicity? To date, published data has shown efficacy in predicting early onset cardiotoxicity. However, studies in 150 childhood and 53 adult cancer survivors of hematological and breast malignancy reported no detectable elevation of TROP and TROP-I after 2 years and 1 year of follow-up. This finding suggests that using cardiac troponin to detect chronic or late onset cardiotoxicity may be less helpful. While cardiac troponin may be a useful indicator of myocyte injury, there is limitation in their reliability to predict cardiotoxicity, cardiomyopathy, subsequent heart failure, as well as overall prognosis. And these are the various, these are few case reports which have highlighted the issue of false positive troponin assay. Because of the high troponin values were seen because of presence of human antibodies interfering. The prevalence of this type of interference is likely to worsen in future due to emergence of immunotherapy in the treatment of wide range of conditions. Coming to natriuretic peptide, now these are various studies on BNPs and NT-proBNP. If you can see, the sample size is so low. Only one study had a sample size of more than 107. The methods is not defined. The cutoffs for these studies are not defined. With this lacking crucial information, the lack of uniform conclusions can be drawn that there is lack of uniformity in the conclusion. Few reported small increase in BNP concentration after chemotherapy. Few reported fully or partially negative result. Overall studies were unable to definitely confirm the usefulness of CNPS cardiotoxic biomarkers. So in lieu of definite evidence, it is not currently possible to recommend the use of CNP assay to assess cardiotoxicity in clinical practice. New prospective studies, large cohort of patients, well validated and commercially available methods are needed. Recent systemic review of this markers, use of this markers for cardiotoxicity prediction in children with cancer showed limited evidence, making conclusion problematic. And these are various studies, again, studied the determining the utility of multiple marker approach. They used multiple marker. And this is the most recent study published in during the lockdown pandemic, 19 May 2020. And this is the data from the ECOR registry. And the opening statement of this is, to date, there is inconsistent evidence for conventional biomarkers as a marker of cardiotoxicity in cancer patient. They studied 485 cancer patients between June 18 to January 2020 to evaluate the diagnostic value of cardiac troponin and BNP for monitoring of cancer therapy-induced cardiomyopathy. And what were the conclusion? Neither baseline value nor follow-up investigation of cardiac biomarker can safely replace advanced monitoring in patient undergoing cancer therapy. Clinical examination, ECG, 2D echo with strain analysis should still be regarded as a preferred screening method for detection of early myocardial damage in high-risk patient. These are all studies on Western population. There is one study from India, Kolkata. They studied acute leukemia patients, 52, and they studied all the biomarkers at baseline after first cycle of doxorubicin, last cycle in 6 months. Except for NT-proBNP, all others biomarkers did not change, and they concluded that negative TROP-T concentration during anthracycline treatment do not identify patients with a low risk of development of cardiomyocyte in future. Hence, because of the limited evidence with present biomarker, the researchers are always discovering and validating promising circulating biomarkers, and this research on this following biomarkers are ongoing. Added to this is now coming up omics technology, which is a systemic based approach, and these information, they are studying information about the protein, then immune responses, detection of metabolite release during the acute exposure, which may predict long-term likelihood decline in cardiac function, and this is the future. Applying the established criteria of evidence-based medicine, well-defined scientific evidence about following question: most effective biomarker, most effective protocol for blood sampling, marker cutoff concentration that gives the best diagnostic accuracy in terms of sensitivity, specificity, and predictive value still needs to be obtained. Role of biomarker as a primary solitary measure is inconclusive. Guidelines support role as ancillary measure. Change in biomarker over time may be more important than baseline level alone. Different prognostic cutoff in metastatic versus non-metastatic disease. Additional research is needed to establish the role of consistent cardiovascular biomarker and new biomarker discovery. Here is my closing statement. Biomarker can be used in conjunction with history, physical examination, and imaging modality to gather information and on-patient clinical status. Unfortunately, there is no single biomarker that can predict the cardiac prognosis of the patient, and the diagnostic and the predictive utility of these measures had been inconsistent. Further going ahead, from patient's point of view, when he sees this biomarker report, he will consult Dr. Google and I confront you with following questions. Can troponin level be elevated in any condition? Yes. In renal failure, heart failure, sepsis, stress, hypothyroidism, diabetes, stroke, intestinal bleeding, and smoking. Do any substance interfere with troponin test? Yes. Hemolysis of blood sample, heterophile antibodies, and biotin. And can troponin result be compared? Yes, only if performed on the same analyzer at a single facility. Testing performed at different location on different analyzer are not interchangeable. If patient is transferred from one facility to another, an additional troponin testing is necessary, and the original sample should be retested. Thank you.
Thank you so much, ma'am. I now request Dr. Hemant Madan, senior cardiologist from Gurugram, to please give the expert comments. Over to you, sir.
Thank you very much. Wow, what an animated debate, really. And for a change, I'm going to turn to a turncoat form of justification. I think the debate topic could have added one or two words which would have made it even more interesting. If the topic was only biomarker monitoring is mandatory for this patient, that is, we exclude echo, then the answer is perhaps no. Then I would agree with the speaker number 2, only if the word only is added. But if echo is going to be a part of the whole protocol, if echo is going to be included, then biomarker is definitely an added information. So there I would go with speaker number 1. Now, the level of evidence, I think both have elucidated the level of evidence, very clearly. What I don't agree with speaker number 2 is regarding availability and cost of all these tests. First is, when we are looking at biomarkers, we are looking at two different things. One is the cardiac myocardial injury part of it, which is assessed by CPK, by troponins. And the other is the heart failure component of it, which we measure with by, checking BNP. Both these tests are now widely available. They are reasonably standardized, so if we are to progress further, then obviously these have to be incorporated in our day-to-day clinical practice. So in fact, my judgment or my assessment would be, what's the harm? They don't add too much to a bill. They are not that costly. I mean, they do add up to some amount in a bill. The advantage is that they give you additional information. So there I would go with, the speaker number 1. But have they reached a point of validation where they've become mandatory? We would need to study them a little more before we say that yes, definitely and dogmatically they are mandatory for all patients in clinical practice. So having said that, my conclusion would be that they are just a few months to a few years short of being made mandatory, but certainly they are desirable. And very many centers, very many chota centers now have, BNP and quantitative troponin I or troponin T. Troponin I is more easily available. So I see no harm. In fact, I think our society should be one of the first to have some kind of a temporal assessment for these, to suggest temporal assessment plans for these kind of situations, to say when we would like to do, have some understanding of historical data to say when troponin I has been seen to be maximally elevated, and come out with some kind of recommendations that maybe say 2 months or 3 months after an anthracycline included chemotherapy schedule, we must incorporate troponin measurements or incorporate BNP later on in the schedule. So having said that, as I said, my concluding remark is that probably they are not mandatory with the current state of evidence, but they are certainly desirable. Sequential BNP and sequential troponin I add up a little more information, and therefore for any rational modern thinking oncologist, I would suggest that yes, you must incorporate them. You might not do them with every chemotherapy cycle, but we must incorporate them. Thank you very much. Really an animated discussion, and it was really nice to see you two fight it out. So my judgment is I will sit on the fence.
Thank you, sir.
Thank you so much, sir. Now we'll move on to the case discussion and the panel. The topic is balancing cardiovascular need for anticoagulation or antiplatelet with bleeding or bleeding risk in oncology. Our discussant or moderator is Dr. Holis D'Souza, medical oncologist from Mumbai. His panelists are Dr. Rakesh Gopal, cardiologist from Chennai, Dr. Nishant Chandra, cardiologist from New Delhi, Dr. Praveen Palliwal, medical oncologist from Bhopal, and Dr. Shruti Kate, medical oncologist from Nasik. Over to you, sir.
Good evening. Am I audible? Is my screen visible?
Yes.
At the outset, I want to thank Purvi sir and Vivek sir for this opportunity. The reason for this discussion is a case that I recently discussed with Vivek sir. And that is the reason we are discussing balanced cardiovascular need for anticoagulation, antiplatelets, bleeding or bleeding risk in oncology. Bleeding in cancer can be due to local tumor invasion, tumor angiogenesis, systemic effects of cancer, or anti-cancer treatments. Our past seminars in ACOS have discussed extensively on cancer and thrombosis. I remember Dr. Khurana's lecture for primary thromboprophylaxis, management of breakthrough VTE, and this particular slide where he has discussed the safety profile of the drugs. But what if a patient presents with bleeding? I am happy that I have distinguished cardiologists on board, Dr. Rakesh Gopal sir, Dr. Nishant Chandra sir, and my senior from TMS, madam, and Dr. Praveen. So I'll be presenting the case 1. I have 2 cases to present today. I'll be presenting the history and the investigations, and then we'll start the discussion. I want this to be more of a discussion than a moderation. I want to learn from my seniors today. So this case was presented to me when I was a senior resident during my residency in Derwan. This is a peripheral center. 51-year-old female, PS2, under evaluation for complaints of fatigue and dark stool, with history of multiple transfusions, presented with anasarca. She had past history of right femoral vein cannulation in the peripheral center in view of difficult venous access. She was investigated with the medicine department. A UG endoscopy showed multiple ulceroproliferative growths in the greater curvature of the stomach. Biopsy was a poorly differentiated adenocarcinoma. HER2 was negative. MSI was not tested. A subsequent CT revealed metastatic pulmonary nodules with growth at the greater curvature extending to the antrum and pylorus, RPA lymphadenopathy, and filling defects in the right common iliac vein, external iliac vein, and the right femoral vein. So impression is a 51-year-old lady with an ECOG PS of 2. is a metastatic carcinoma stomach and right femoral vein thrombosis with tumor bleed and malign. So the challenges that I faced, I want the discussion with my senior colleague from the oncology team. I request Dr. Shruti Kate madam to take this question. What are the therapeutic options you will take to tackle malignancy and bleed, especially in this patient? What will you tackle first? Will you tackle the bleeding first? Will you tackle the thrombosis first?
I will tackle the bleeding first because I need to hemodynamically make her stable before I can treat her for her metastatic disease. So I would want her to stop bleeding first. So yeah, so I see at this point debulking surgery and all cannot be done. She is performance status 2 and this is not an option for a metastatic patient. I would want to take the option of hemostatic radiotherapy, which is a short course radiotherapy done with the intention of ensuring hemostasis. And this we have tried in very many patients and have successfully stopped their bleeding. Someone who was requiring PAT cell transfusion every 4 to 5 days have become transfusion free. So yeah, so we would want to use a hemostatic palliative radiotherapy, stop her bleeding, and then take care of her systemic disease. Yeah. Angioembolization may not sometimes help for a bleed, for a large tumoral bleed, because there is no single vessel which is feeding the bleeding. So it's the entire tumor that is bleeding. So here you can go ahead and do a CT angio, but most of the times what we see is we don't find an active source of bleeding, and the patient is still, losing out on blood and her hemoglobin is dropping. So I have gone ahead with angioembolization only when we have been able to identify a bleeder, mostly in a intestinal bleed or something. For stomach, I have not found it very helpful. The CT angio, I would want to do it to localize the bleed, but here it is very apparent that the tumor is bleeding. So I would want to do a biopsy like that has been done, and then go ahead with the palliative hemostatic radiotherapy.
Thank you, ma'am, for your inputs. This is what I had exactly done. I had started with the hemostatic RT, and in the meantime, I had taken up for CT angio. But as we had discussed, CT angio did not show any bleeder. Tumor, it is a vascular tumor, so it has not shown us any bleeder. So we went ahead with the hemostatic radiotherapy. The next option faced with the oncology team was the therapeutic option. I request Dr. Praveen to discuss the next, the palliative chemotherapy options, considering the risk of thrombosis and considering thrombocytopenia, whether he like to go for a 2-drug regimen or a 3-drug regimen. Praveen, sir. Yeah.
Correct. So I will start with the 2-drug regimen only because the patient is bleeding thrombosis. So 3-drug, because hormone PS is 2, so patient cannot tolerate 3-drug regimen. So 2-drug, either because either the capox or the Folfox for this patient.
Considering the thrombotic risk of platinum, sir, would you still consider for a platinum-based backbone?
Correct. So either the question is relevant, but the thrombosis risk is more with the cisplatin, with the oxaliplatin is slightly less, and even because with the thrombosis, their patient will need the anticoagulation at some point of time. So my option will be to go for the 5-FU with the oxaliplatin or the captopril.
Thanks a lot, sir. So my next question for you is, this is the carcinoma stomach, but what about chemotherapy in vascular bleeding tumors? Now we are looking for bleeding and we're looking for both cardiology and the oncology part. How would you modify your oncology regimen on bleeding tumors like hemangioendotheliomas, angiosarcomas? Would you still go for chemotherapy? Would you like to go for something else? Vaccines or
anti-VEGF? If the histology is angiosarcoma, so my option will be the taxane because they are the regimen of choice for the angiosarcoma. So I will use the paclitaxel drug for the as a part of chemotherapy regimen.
Okay, sir. And any options for anti-VEGF? Do you feel we can use them in bleeding tumors with thrombosis?
I'm not so sure. So for the angiosarcoma, taxane will they are the regimen of choice. So for the anti-VEGF, I'm not sure.
Okay, sir. We'll have further discussion on this. I now go to the challenges faced by my cardiology team. I request Rakesh Gopal sir to take the first question. What are the optimal approach to tackle thrombosis in a bleeding patient? As Dr. Shruti has mentioned, she'll first control the bleeding, but the thrombosis needs to be taken care of. Now, this is a patient who has a large deep vein thrombus and she is bleeding. I request Rakesh Gopal sir for input, whether anticoagulation, devices, whether you go for an angioembolization. Hello, Rakesh sir.
Rakesh sir, you'll have to unmute your mic.
Yeah. Sorry. See, the no question of anticoagulating somebody who's already bleeding. Angioembolization can be considered for bleeding, but I will definitely put an IVC filter. That will be my first option. I'll put an IVC filter, and then you can proceed with an embolization to stop bleeding or whatever. And again, at the same time, the cancer therapy can be taken up. If you're using 5FU in this patient, already there's thrombosis. Coronary thrombosis do occur with 5FU component, so we should be careful in that part. But however, best form of cancer therapy must go on, and that's what the cardiac oncologist's role is. Put an IVC filter and then proceed.
Sir, I have a question because this patient came with a right femoral cannula in situ. It was not a catheter, it was a cannula in situ. So yeah. For a catheter-related thrombosis, would you advise me to take the cannula out? Would you advise me to keep the cannula in situ? Do you want me to?
Don't at this point of time, because then it may lead to embolization straight away. You can put a filter through the jugular vein, and then you can remove the catheter.
Okay, sir. Thanks. I request Dr. Nishit sir to please take the next question. Anticoagulation in bleeding and thrombocytopenia. Is there a safe drug? Leave aside this case. This patient is bleeding, but what about patients who are at bleeding risk? What about patients with thrombocytopenia? So of the 5 drugs that I have, which of these drugs would you think I should be starting first?
Right. So, yeah. So, thank you very much. Thank you, Dr. Purvish Parekh and Pankaj Chaudhary, my friend, for including me in this very, very important and the need of this synergy between cardiologists and oncologists. Because many times we are called to give opinion on a cancer patient for about thrombosis, for starting anticoagulant or not. Now, this is a dilemma. We have to make a tightrope walk in a patient who is having thrombocytopenia because of the cancer chemotherapy or the cancer itself, and he's having a high risk of VTE or thrombosis. So basically, what we have to do as a clinician is, there are no set rules. We have to basically see the bleeding risk as well as the thrombosis risk. Like in stroke prevention, we use a Hasblad score. It's a Hasblad score basically guides us whether this patient is having high risk of bleeding or not. So, which includes H for hypertension, A for age more than 75, S for previous stroke, B for bleeding diathesis, liver dysfunctions, and elevated liver enzymes, elevated INR, and drugs. So by this calculator, we calculate the bleeding risk. On the other hand, we also calculate whether this patient is having high risk of venous thrombosis, whether he's a bedridden patient, whether he has had a proximal DVT in iliacs or upper femorals, and whether he's an active carcinoma. But these are the patients who are having very high risk of thrombosis. So we have to basically make a tightrope walking between high risk of bleeding versus thrombosis. And if the patient is having thrombocytopenia, then it makes our job very difficult. So the cutoff safe level of platelet count is 50,000. If the platelet count is more than 50,000 and the risk of thrombosis is there, more bleeding, bedridden patient, proximal thrombosis, then you should give an anticoagulant. And anticoagulant, the maximum data is with low molecular weight heparin, the enoxaparin or dalteparin, 1 milligram per kg subcutaneously. So you can give heparin also, but heparin is notorious for causing heparin-induced thrombocytopenia. Now, as far as a safe NOAC is concerned, dabigatran, edoxaban, and rivaroxaban, there is only one study, Hokusai study, which compared dalteparin, which is a low molecular weight heparin, with edoxaban, and it found that there was no difference between the bleeding risk, and it was as efficacious in preventing VTE. But there is a lack of data between the availability of the apixaban and rivaroxaban and dabigatran, which are available in the Indian market. So for the time being, we are comfortable. We as cardiologists are comfortable if the platelet counts are more than 50,000 and the patient is having high risk of VTE, then we put the patient on full dose low molecular weight heparin. If the platelet counts are below 50,000, then again we have to assess the risk of thrombosis. If the risk of thrombosis is more, then we have to put them on half dose of low molecular weight heparin, 0.5 milligram per kg, or even hold low molecular weight for some time and assess. And as Dr. Gopal also has alluded to, if the risk of thrombosis is very high and the risk of bleeding is also high, we can't give an anticoagulant, then the best thing is to prevent pulmonary embolism, because DVT does not kill, it's the pulmonary embolism which kills. So we have to prevent the migration of that thrombus up to the lungs by putting a barrier in form of an IVC filter. And mind you that putting an IVC filter is a child's play. It just takes 5 minutes on the table. Either you can go for the groin from the below, or if the groin is full with thrombus, you can go from the internal jugular vein from up. And one more thing I would like to emphasize here is, now there is no role of a permanent IVC filter. You should always put a temporary retrievable IVC filter whenever the patient's risk of thrombosis goes down, and you can initiate an anticoagulant, then you should always remove IVC filter. So put a temporary IVC filter to tide over that period of increased thrombogenicity and remove it as your earliest opportunity.
Yeah, thanks a lot, sir. So we did put an IVC filter for this patient, and we continued her hemostatic RT. We were able to achieve hemostasis, and we started her on a 2-drug regimen. The other challenges faced with that we have faced, especially if the patient is on anticoagulants and I want to take him up for an urgent surgery. Request Dr. Rakesh Gopal sir, if the patient is on low molecular weight heparin or dabigatran or rivaroxaban, what are the recommendations you'll want for the reversal of treatment? How long can I wait? What is the bleeding risk for surgery that I need to decide? What does the cardiologist need to tell me that this is a safe period, this is a safe procedure, I need not stop the anticoagulant? Request Dr. Rakesh for this.
The risk of bleeding, if you're planning for a surgery, is a real challenge. So if the patient is on heparin or even a newer anticoagulants, like even 10 antagonists, then the real challenge with, if you stop the drug in about 6 to 8 hours time, you can have one half-life out. And then if you have stopped for 1 day, then 3 half-lives really goes off. So you can, majority of the time, this is not a big problem. A reversal agent is available only for one agent. So right now in the market, theoretically one more. But whatever said and done, I have never had an opportunity to use a reversible agent myself, and because it was not required almost every time. You can, it's only theoretical possibility that you require an reversal agent. Most of the time, reversal agent is not required. You can proceed with surgery. By the time patients bleed up and you have already stopped anticoagulant, by the time patients in the hospital itself, know that the effect of the drug is mostly gone. That's been our experience.
If I may come back here.
Yeah, please.
Yeah, so we have an occasion at Scott's Heart Institute, the chance of using a reversal agent. The patient was on dabigatran, and which is a direct thrombin inhibitor NOAC, and the patient started having intracranial bleed. So the surgeon had to do a burr hole. So we ordered a Traxbine, which has to be given in 2 doses of 2.5 grams. So total of 5 grams at a 15 minutes interval. And it almost immediately, it reverses the dabigatran bleeding potential. And the patient went for this burr hole, and then this anticoagulant were resume after the surgery. So the presence of reversal agent is giving us a confidence, but right now the reversal agent is only available with dabigatran. The reversal agent is available with the name of Prexbind. It's available in 2.5 grams vials. 2 vials have to be given, total of 5 grams intravenous bolus. The reversal agent for rivaroxaban and factor 10 inhibitor apixaban is on the cards. It is going to be available with the name of andexanet alpha. So that is also very soon it will be available in India. Though these reversal agents are very, very expensive and should be used judiciously only in emergency cases. And as Dr. Rakesh has already told, that the half-life of these NOACs is very low. So if you stop them after 12 hours, their levels rapidly fall. So after a day or so, you can safely perform a surgery.
Thanks, sir. This is a wonderful information that you provided. I was aware about dabigatran. I was not aware about the medicines in pipeline. Requesting you to take the next question. Does the tumor define the anticoagulant? Would I use a different anticoagulant for a GI bleed? Would I use a different anticoagulant for a non-GI tumor, like a CA breast or a CA lung?
Right. So any bleeding which is internal, which is non-compressible, which is there, I would definitely use an anticoagulant which has less bleeding. Like in if we compare all these NOACs, apixaban has the least bleeding tendencies. Dabigatran has more bleeding tendencies. So I would prefer apixaban over these dabigatran and rivaroxaban for internal bleeds. For non-GI bleeds, I can use either because you can compress the bleeding out.
Especially for mucosal bleeds.
Yes, you can safely, if it is internal, then certainly you should use a agent which has the least bleeding tendencies. And in that, apixaban aliquis, which is available in our country, is having least bleeding tendencies.
2 minutes left, sir.
Actually, this is the end for the case one. Do I get 5 more minutes?
No, I think you will have to close now, summarize.
Okay, sir. This is one last question that I wanted to discuss with Dr. Rakesh and Dr. Nishit. This is a patient. My second patient was a patient who was post-PTCA and presented with GI bleed, stomach bleed. So I wanted Dr. Rakesh's opinion on what are the stent types that my cardiologist should be telling me. Are all stent, all cardiac devices MRI safe? And if this patient who is a carcinoma stomach post-PTCA should be continued on dual platelets or single antiplatelets? Requesting Dr. Rakesh for this question.
The stents are cardiac MRI are compatible, so should not be a problem. Patients can have an MRI, and even the heart valves, recent the TAVI, that's also MRI compatible, so this should not be a problem. Stent types
and bleeding tumor
anymore.
Okay.
You can
tumors
use
are antiplatelets, dual or single.
You should see bleeding risk for the first 4 weeks. You should use the dual antiplatelet drugs. Then you can come down to single agent. In this, people at high risk of bleeding. The stent types, if you say, you can use the DES, but there should be a bioabsorbable polymer coated stent. In that case, it won't be a problem.
And the last question I want to ask Dr. Nishit, sorry for the shortage of time. We have discussed this in the WhatsApp groups and discussed this in various forums. Are you using prophylactic nitrates with every 5FU infusion?
So honestly speaking, at our hospital, it's not a cardiac center. So I have not got an occasion to treat patients on 5FU infusion. So maybe Dr. Rakesh can enlighten us because our hospital is totally a cardiac hospital.
Dr. Rakesh, any experience with this?
Yeah, see that there is no evidence that such a therapy with a prophylactic nitrate infusion should be given along with the 5FU. But we practically give aspirin 75 milligrams plus rosuvastatin 20 milligrams, and we also give calaptin, that is verapamil, as a prophylactic measure for everyone on 5FU infusion. And we continue the therapy as much patient is on 5FU or on capecitabine. Nitrates, the thing is, unless the spasm occurs before that, the nitrate can prevent a spasm, we are not very sure. There are no guideline-based
no
basic
guideline for this. That is the reason I wanted your expert opinion.
Yeah, there's no guidelines on it at all. So there's no institutional preferences. Maybe the nitrate can also help, but this is what we do because it is a spasm and it is it's the thrombosis, or maybe together it's causing this particular syndrome while patients on 5FU infusion or afterwards. So definitely these measures can help. But if you ask me what evidence I have, I don't know. I'm not sure. There's no such guideline, but we have not had an event afterwards. But during the last 5 years, I've been using this, and I never had an event of 5FU related infarct after that. But that is not static. That is not statistic.
You use that for all patients, sir, or for patients who have an underlying cardiac issue or anything?
No, we use it for all because there is something very particular about 5FU. 5FU is a trigger. It's not a risk factor. So it's a trigger. It can cause infarction irrespective of the risk factors. And the risk of infarct is more in those patients who have already had a cardiac event. But the
Thank you very much. I think we'll have to stop now because we are really.
I apologize for this. And thank you for your time. Thank you for your patience. And thank you for a wonderful discussion. Request Kashish to take over. Thank you, sir. Thank you,
Thank you so much, sir.
Thank you, Hollis. Thank you.
Thank you so much, sir. Now we'll move on to the last part of today's session. The topic for the session is keto and medical crowdfunding. And our speaker is Mr. Rohit Chand Chanikar, who is the Vice President of the Healthcare Division of Keto. Over to you, sir.
Thank you very much, Kashish. Good evening, everyone. And thank you very much, Dr. Purvesh, for giving us a chance. Okay, Kashish, can you just expand the screen, please? Okay, that's fine. Okay. Okay, guys. We come from a company called Keto. Now, Keto is an online crowdfunding platform where we help raise funds for a lot of underprivileged patients. Now, Keto is about 8 years old, and we've partnered with more than about 250 hospitals throughout India. And in the past 8 years, Keto has basically helped raise more than about 1,000 crores for all our partners. Can we go to the next slide, please? Okay, now what kills India, correct? So, we have a lot of diseases over here in India, and, like lakhs and lakhs of people, unfortunately end up losing their dear lives. Can we go to the next slide, please? Okay. So the problem over here is that, around 25 lakh of people, die in India. Why? Because these people do not have the exact amount of funds for their cause, for their medical treatment. So, that's why, organizations like Keto, okay, believe, where, yes, we can end up raising funds for the underprivileged patients. Can we go to the next slide, please? Okay. So, as I said, that, that there are so many people like in India who actually do not, have got like medical insurance. Okay. So, when, say, for example, like an accident occurs, or say, when any of the family members, get diagnosed with cancer, or say, in terms of transplants, kidney transplant, liver transplant, whichever transplant it is, they fall short of funds, So, that's where, yes, can you go to the next slide? Okay. Solution for that is crowdfunding. Now, I would like to introduce you to crowdfunding. Okay. Now, if I, were to tell you in very simple terms, I'll just like to give you an example. Okay. Now, say, for example, if, there is a bus driver and his 5-year-old son is suffering from cancer. So this bus driver takes his 5-year-old son and he walks inside Fortis. He shows the doctor. The doctor tells him, saying, well, your son's suffering from cancer, and the treatment is about 20 lakh rupees. Now, that's when the bus driver tells the doctor, saying, doctor, I'm sorry, but I don't have 20 lakh rupees. What am I supposed to do? Now, that's when that particular doctor, okay, tells that patient that why don't you get in touch with Keto? Now what Keto does is that, okay, Keto will first verify the documents of the patient. Okay, we will basically verify the cost estimate letter which comes from the doctor, which says that the patient name is XYZ, patient is suffering from ABC, and the cost of treatment is about 20 lakh rupees. Now, once the verification of the documents are done, the Keto team conducts a photo shoot of the patient in that particular hospital premises. Okay. And once the photo shoot is conducted, the Keto team interviews the bus driver, okay, which is the patient's father. Now, why this patient's father is interviewed is because, you know, we basically interviewed them in terms of getting down the entire content for the article, for the campaign, which Keto has to put together in terms of raising funds for this patient. So say, for example, you know, like the content could basically say, well, I'm a bus driver, I've got 20,000 rupees per month, I've got 5 people in my house to feed, my wife works as a maid, XYZ, whatnot. Now, once the photos have been taken, once, you know, like the interview has been done, okay, all these things are put together and an online campaign is created. Now, Keto has our own in-house digital marketing team, okay? Now, what the digital marketing team does is that they basically amplify this campaign, okay, throughout the audience, throughout the globe, okay? So, you know, people, you know, get to see Keto ads on Facebook, they'll get to see Keto ads on YouTube, okay? And, you know, that's where, Keto basically ends up raising funds for the underprivileged patients. Now, say, you know, if the cost of treatment for this bus driver's son was about 20 lakh rupees, and, you know, the campaign went on for, say, about 2 weeks, 3 weeks, 20 lakh rupees have been raised for the patient. Now, these 20 lakh rupees get transferred directly into Fortis' account, and then that's how the patient gets treated, okay, for his particular cause, for his particular treatment. So in short, that's how crowdfunding basically works. Can we go to the next slide, please? Okay, so why do you think people should try, okay, medical crowdfunding? Now, if you if you come to think about it, right, it's one of the best ways, you know, in terms of going and asking your friends, going and asking your family, or else, you know, Keto will basically help you get donations from throughout the globe. And when I'm talking about medical crowdfunding is completely donation based. Correct? So it's not like, you know, you're going and taking a loan of, say, 10 lakhs, 15 lakhs, and then you're paying X amount of interest on it. And, you know, then of course, you know, you're already so cash rich, and, you know, then you're unable to pay your loans. So when I talk about medical crowdfunding, it's very, very beneficial because it is completely donation based. Can we go to the next slide, please? Okay, so you know, to partner with Keto, you can definitely get in touch with me. My phone number is on the screen. I shall also share it on chat. A few more things that I would just like to tell you. You know, as I said that, you know, Keto has got presence in about 24 cities throughout India. You know, tier 1, tier 2, tier 3 cities. You know, Keto basically works with the biggest of the biggest brands in terms of the hospitals, you know, whether it's Fortis, Apollo, you talk about Rainbow, you talk about Narayana, all of this. If I were to just, you know, give you some statistics, so say Fortis Hospital, which is there in Bannerghatta, Bangalore, Keto has been working closely with them since the past only 8 months. And since the past only 8 months, Keto has basically ended up raising 3.4 crores for all their patients. 3.4 crores in the past 8 months. That is the impact, so that is the impact that, you know, Keto has basically made for the patients and for our partnering hospital Fortis. Another example to give you is, you know, Kokila Ben Hospital, which is here in Bombay. We've been working closely with them since the past 3 years. With Kokila Ben, you know, Keto has basically ended up raising nearly 8.5 crores in the past 3 years. And of course, you know, as you know, our vision and mission are, you know, where we definitely want to go ahead and help a lot of underprivileged patients. And you will be very, very surprised to know that, you know, Keto has got a very huge donor database outside of India as well. You know, we see funds coming in from the US, we see funds coming from the UK, Canada, Gulf countries, Southeast Asia, you know, whichever part of the globe, you know, people can contribute. Okay, ads, you know, get sent to them. People come and contribute. And one of the most beautiful things at Keto, you know, which we've seen is that, you know, unknown people, okay, come ahead and help unknown people. Correct. And, you know, we've had so many success stories at Keto, you know, like say, as I was talking about the bus driver's son, unknown people, come together and end up raising funds for somebody. So that's the like beauty. And of course, at Keto, what we are trying to do is that we are basically trying to bridge the gap between the people who want to go ahead and like help, and between the people who basically need help. That's what Keto is all about. So I'm open to any question and answers right now.
So what does Keto means? K-E-T-T-O.
Very good question, doctor. Keto basically means key to tomorrow.
Oh, that's wonderful.
Yes.
And what is your business model? How do you make money, or how do you survive?
Definitely, sir. So, when I said that, Keto basically creates the campaign and then Keto advertises it, right? So Keto has partnered with Facebook, Keto has partnered with Google and various ad platforms. Okay. Now, so we partnered with various ad platforms, and so what Keto basically does is that we keep a percentage of the funds raised. Keto keeps 13% of the funds raised.
Okay.
Yes.
Right. And
yes.
So suppose tomorrow a poor patient walks in my hospital and requiring a bypass surgery. So I can safely give him your number?
You can definitely give my number, but just a couple of things in terms of crowdfunding, which I would definitely want to share with you is that when you talk about crowdfunding, something which we've seen in the past 8 years, like the crowd basically ends up donating more towards pediatric cases than towards adults.
Okay.
So I'm not saying that adult cases do not work. But yes, like the crowd ends up donating more towards pediatric cases. Adult cases do definitely work. But yes, I mean, the percentage success rate is basically more towards pediatric cases.
So if I have a patient who requires crowdfunding and I refer him to you, how quickly do you do the due diligence and set up the system so that they can start receiving the funds? Because for cancer patients, time is the essence.
Understood. So see, I mean, if I, were to like rephrase your question, so to create a campaign on Keto, it will, take you like less than 20 minutes.
Wow.
Okay? But of course, in terms of due diligence, okay, because Keto would also want to take the KYC of the patient. Okay,
Yes.
we want the Aadhaar card, PAN card, everything. Make sure, plus check their additional medical documents. So this process could take anywhere between 24 to 48 hours. So within 24 to 48 hours, once the photo shoot is done, once the documentation is complete, once the documentation is verified, within 48 hours, the campaign link will be created. Okay.
Right.
Now, in terms of seeing the funds coming into the campaign, or understanding whether a campaign is going to be successful or not, okay, it will usually take anywhere between 2 to 3 weeks in terms of understanding whether this campaign is going to get successful or not.
And typically, how long does it take to meet the goal that a particular patient has in terms of fundraising?
As I said, so basically crowdfunding is all about storytelling. So say if there is a, say for example, if there is a single mother, husbands no more, okay, and if such kind of a campaign is amplified out there, so we've seen that such kind of campaigns get funded even within 24 hours, okay, or else it could even take 3 weeks, correct? So it's all about that emotional quotient which has to be there in that particular campaign.
Rohit, I have a question.
Yes, sir.
Now, whenever we surf a net, we get lots of pop-ups. They pop up like so-and-so child is very sick with cancer or is dying of cancer. So, and you donate at this number. So we are not sure whether this is a hoax, a scam or something. So what is the truth behind these pop-ups?
Okay. So, I mean, I would definitely not, want to comment on any other platform or, any of these pop-ups, but what I can talk about is Keto. Okay. So at Keto, we will not promote any campaign unless and until we have the cost estimate letter from the treating doctor. Okay. So we basically have an on-ground team that goes and talks to the doctor and finds out whether this patient is actually there. Okay, then we take the cost estimate letter from the doctor, which says, yes, the patient is suffering from this and the cost of the treatment is XYZ. Now, once that cost estimate letter is given, that cost estimate letter is actually uploaded on the campaign. So say, for example, if I'm, like sitting in California and, if I like come across this particular pop-up of Keto, which, talks about a patient which is from, say, Pune, correct? Now I can actually go and check the entire medical documents. Now on that particular medical documents, I will also see the doctor's name. Now, if I want, I can actually pick up my phone and call up that particular hospital which is there in Pune and find out. In fact, doctor, you'll be very, very surprised to know, yes, there is a very good percentage of people who actually call up hospitals and find out. And that's a like very, very good thing for Keto, because yes, Keto believes in complete transparency.
How it is different from GoFundMe or Indigo or Kickstarter.com?
So how it is different? So I'll tell you one thing. GoFundMe, okay, GoFundMe is a platform. So basically, when you talk about crowdfunding is always of two types. Okay, one is where anybody can come and create a campaign of themselves. Okay, and once that campaign is like created, then that campaign link you will only share amongst your own network of friends. Okay. Second type of crowdfunding is where that crowdfunding organization ends up doing everything for you. So to answer your question, GoFundMe, okay, does not have an amplified model. Okay, GoFundMe will not promote your case on a Facebook, correct, or on a YouTube, because you will not see GoFundMe ads.
And is Keto only limited to medical help or beyond?
No, doctor. No, doctor. So Keto works very closely with a lot of NGOs as well. Okay. So if you were to talk about CRY, if you were to talk about Save the Children, if you were to talk about Water Aid, so Keto, ends up raising funds for a lot of social causes.
What is sometimes cancer patients require a lot of money.
Correct.
For instance, there is a patient who requires a bone marrow transplant. Are you able to raise that level of funds like 10 lakhs, 15 lakhs also, or it is just 2-3 lakhs, 4 lakhs?
No. So, doctor, to tell you in terms of bone marrow transplants, bone marrow transplant cases every month, Keto ends up funding at least minimum to about 20 to 25 cases in terms of bone marrow transplants.
Really? That many?
Yes.
Wow.
Yes. So, ending up raising 25 lakhs, 35 lakhs, yes, I'll be very, very honest, ending up raising 25 lakhs per case for Keto 5 years ago was very, very difficult. But then, now, of course, Keto has basically, mastered this particular industry. And yes, I mean, 35 lakhs is actually not too much of a big deal, when it comes to Keto.
Nice.
Yes.
Very good initiative.
Thank you very much, doctor.
Who is the person behind Keto? Somebody must have really used their brains to come up with this idea.
Definitely, doctor. So the founder of Keto, his name is Varun Sheth. Okay. So he's actually from Bombay itself. And the co-founder for Keto is this Bollywood actor called as Kunal Kapoor. I don't know if you've seen the movie called as Rang De Basanti, but the tall person movie.
Not Sonu Sood.
So, well, yes. Talking about Sonu Sood as well, doctor. Keto works very, very closely with Sonu Sood as well.
Hi, doctor. This is Varun Sheth here. I'm the co-founder at Keto. This is a fantastic opportunity for us to come and speak to all of you all and talk about the work that we're doing. And we really hope that you'll like this idea and give us a chance to engage and help more patients in the near future.
Varun, very nice initiative and very noble initiative.
Thank you, sir. Thank you.
But not many people know it. Not many doctors know it. So you have to advise it.
That is correct. That's why we are here, doctor. We actually want.
I'm from Fortis Escorts, New Delhi, and I'm from Fortis Escorts, New Delhi, and I didn't know that such a platform exists.
Yes, doctor. That's one of our key goals to be here and to do more to promote ourselves in the doctor community and show the impact of crowdfunding and how crowdfunding can really help a large volume of patients in a country like India where out-of-pocket expenses are so high.
Doctor, I'm planning to visit Delhi next month. So I would definitely want to come and visit you, Dr. Chandra.
Yeah, you can most welcome at Fortis Escorts Heart Institute, New Delhi.
Definitely, Doctor.
Happy to take more questions as well.
Over to you, Vivek.
Yeah, I think we will conclude, and I think we had a really satisfying program today with really a great bit of learning, and I take this opportunity to thank everyone to take out their valuable time and attend this meeting. Thank you all the speakers and the moderators.
If I have a suggestion to make as a cardiologist.
Yes, sir. Yes, sir.
Purvish, now as a cardiologist, we don't have any clue about the malignancies and chemotherapies and newer drugs, tyrosine kinase inhibitors and all, because when we did MBBS and MD, it's a long time. So why don't these oncologists, they make a web series of oncology for cardiologists, like dummies for, because we are totally, you can say, dumb as far as oncology. Whatever terms you are using is totally foreign language for us. So if you can initiate this oncology for cardiologists, it will be a very good bridging thing for understanding.
Sir, if we can work together on this, then we can, give birth to this initiative. It's a very good idea. Correct. I'm all for it.
And the reverse is also true. We can initiate topics cardiology for oncologists.
Absolutely. Perfect.
So the basic, so the idea behind Cardio Oncology and creating this Asian Cardio Oncology Society was to, sort of bring the cardiologists and the oncologists together so that we can discuss all the issues together. And as you would note that in our lecture series, we are organizing sort of small talks of basic cardiology for oncologists. And similarly, we would be very, very happy to, sort of organize similar basic oncology stuff for cardiologists. So your point is well taken, sir, and we hope to work more on this. But again, sort of, sir, I would like you also, as well as to all the general physicians and the cardiologists present here, as to take some initiative so that we can ensure more membership of cardiologists and physicians into this society, as well as to increase the attendance of cardiologists as well as oncologists. So this is one thing that I would request everybody, as well as to you, sir. If you can encourage your colleagues, your people in your department to join the society and to attend this meeting. The meeting resources since our inception of the meeting, as well as the starting of Asian Cardio Oncology Society meetings, they are all there uploaded on YouTube, and all the lectures that we have had so far is available there, so you can access them and look at how cardiologists as well as oncologists have sort of deliberated upon important topics.
So do we have a website also where all the
yes sir we have a website, www.acos.info, and it is a fully functional website, and the details are all there regarding whatever programs that have been done, as well as what is the future. We have a newsletter that we have started since this year, and we are going to have a monthly meetings. So this is the second of the monthly meetings, and and we are going to have a meeting monthly.
So are these slides available on the website also, cataloged?
The slides are not available.
The talks,
the presentations and the talks are available, sir.
On the website also?
Yes, sir. The ACOS, Asian Cardio Oncology Society, has its own YouTube channel, and you can go through the past meetings in that YouTube channel. It gets uploaded in the YouTube channel.
So are these
free for access, sir?
So are these subject-wise catalogs? Suppose I want to see something, especially with brain tumor or something specific. So can I search that?
So currently, sir, we don't have these lectures being catalogued as per subject wise or topic wise. It is just meeting wise or date wise. But you can access the schedule as well as what was the previous topic and the previous agenda that is available. So maybe if you want to search for it, then you can. But
if you can catalog it, it will be
that is a
Dr.
good
Nikhil,
idea, sir, and we will
excellent
definitely
idea.
look
I think
forward to
we have to implement
taking
that.
some step in that.
It will make it easier and therefore accessible to everybody.
Yeah.
There are some oncology courses, high impact cancer research program of Harvard University. Cardiologists can enroll in it. Actually, I have done it.
Excellent.
You can, it's a 1-year program. If anyone interested, they can take it up, and it's really one of the best people involved in it.
Excellent.
It's a 1-year program. It's called HICR, High Impact Cancer Research.
Dr. Shakya had a suggestion about the slides. So all those speakers who are willing to share their slides, that means they don't want to keep their copyright, we will be happy to share with our colleagues. But it is dependent on the individual speaker whether they will allow it. But the recordings are all available. So I think you can identify the relevant slides and copy them as required. Back to you, Vivek.
Yeah. So again, sir, it is really wonderful to have the suggestions, and the basic premise was that since the inception of Asian Cardio Oncology Society, we are going forward with our monthly meetings, and we have completed the second meeting today. Going ahead with again the same thing is that we all need to encourage our colleagues to join the society so that we can involve more and more people and increase this community of cardio oncologists, because this is again a burning issue that comes, and the future is better only if the cardiologists and the oncologists they work together. Again, wonderful meeting, and we will look forward to the next meeting. Before ending, I must thank our sponsors for today's meeting, Lupin Cardiology and Lupin Oncology, for as well as Keto for supporting us. And if there are any more suggestions, you can write to us on our email. All details of contacting us is available at the website www.acos.info. The membership forms are also available. So wishing all of you a very good night. Thank you for attending, and see you again in the next month's meeting. The meeting will be held every Wednesday, every first Wednesday every month. So thank you, and see you in next meeting.